All right, hello, it's Katie Wiskar from UBC IM POCUS, and today we're just going to go through some slides of pathology to give you guys an example of what to expect when you're scanning the internal jugular veins, the JVP, and the IVC in your patients. Okay, this first slide, this is just an example of a collapsible IJ, so a non-elevated JVP. And you note in the text I've indicated here that the patient is lying flat because obviously it really matters how the patient is positioned when you're scanning the IJ. So this would be an example of the point of IJ collapse you would identify with your ultrasound. This next one is a long axis internal jugular vein. That's the top anechoic structure you see on your screen. You can see that large tubular carotid just deep to it as well. And what we're looking for there is the taper point, so that point where the IJ is coming to a nice taper. You may not see it completely collapse because there will always be a column of blood that is draining from the head, but you should see it come to a nice taper point that should correlate with the taper point you found in your short axis view. This again is just a demonstration. This is probably what I would call the point of collapse in short axis. And in general, I find the point of collapse much easier to find in short axis than long. So I always suggest starting with this. We see carotid deep to it underneath here. This is an example of how we can make our IJs larger with forced expiration. So you can see that the IJ is growing as the patient is doing a forced expiratory breath. So remember that we want to scan the IJ kind of with quiet, easy respiration and not in patients who are bearing down, for example, or doing a Valsalva. This is a fun little skipping rope in the IJ. This is a valve. So all veins have valves. This is normal. If you see this, this is not a clot or something really sinister. This is just a valve in a vein and it is totally normal. They don't always appear quite as nice as this. Here we just see a clip where we're slowly following the IJ up in short axis to find the point of collapse. So you can see the IJ size decreases as we follow it up and it becomes less kind of rounded and more sort of triangular and collapsed here compared to the carotid that's adjacent to it. You also get a nice view of some thyroid here on screen right. This would be an example of an IJ that really supports an elevated CVP. So, we can also talk about IJ size in addition to just the point of collapse. And when the IJ is clearly much larger than the carotid and is very round, those factors also really support an elevated CVP. So if this patient was lying down, then certainly the next step would be I would sit them all the way up and see if I can find the point of IJ collapse with them sitting up. But certainly this initial image, regardless of their position, is strongly supportive of a very high CVP. Here, the image is a bit grainy, but what we can see is IJ overlying the carotid. And what you can't tell, but what we're doing in the clip is we're actually trying to compress the IJ. And you should always do this, for example, before you're putting in a line to check for clots, because blood clots often appear as hyperechoic and kind of brighter, but fresh clots don't always. Fresh clots can actually appear quite anechoic, as is the case here. And so the way you know they're there is you apply some compression to the IJ and you see that it cannot compress, and that's really suggestive of something in there that shouldn't be. So in this case, thrombus. This is that same patient, and now we put some color on just to kind of illustrate this again. Reminder that red is not arterial and blue is not venous. This is just a matter of directionality of blood flow relative to the probe. But you can see that in that top vessel there's a clear filling defect where the color doesn't go. So that again is clot. One more time, just a nice example of the point of IJ collapse seen in the short axis as we're kind of sliding up the neck here with the carotid deep to it. And again, this is another example of a really big IJ that supports an elevated CVP. You can see that it does get smaller as we slide up the neck. And so again, If you found this, you would want to sit the patient at 90 degrees, right? And really try to find that point of collapse. But the fact that it is so big relative to the carotid, again, is very supportive of an elevated CVP. This is another nice example of an IJ getting bigger with Valsalva. So a reminder that our respiratory effort affects things. So there we have carotid, little collapsed IJ as it's frozen right now. And then we will see with Valsalva that the IJ expands. This would be an example where I would say I can't see the point of collapse of an IJ. So we have the IJ there, the smaller carotid deep to it, which again, when the IJ is bigger than the carotid, that suggests that CVP is elevated because it should not be normally. And we're sliding up the neck here, and I still can't really see the IJ collapse. It still looks quite spherical and rounded. It never looks kind of triangular and collapsing. So I would say in this patient position, the point of collapse is not seen. This is an IJ that doesn't look normal. So we have the anechoic or black carotid deep to it. And then the IJ itself looks really bright and hyperechoic. So this is what slightly older blood clot can look like, quite hyperechoic, which obviously is very not normal. Here's just an example of what the variation in an IJ looks like in the setting of severe TR, which is quite common in a lot of our patients. And a reminder that in the case of TR, we want to look for the height of the IJ at its lower point, not the highest it goes with that big CV wave, but kind of where it comes down to. That's where we want to measure the IJ, or the JVP, I should say. Here's a long axis clip. So carotid is deep. The IJ is lying more superficial, looking very distended, right? You can imagine that this is probably going to be a big rounded IJ if we were to switch to short axis. And here we're not able to see a taper point. So we would follow this as high as we could, right up to the jaw. We would sit the patient up. And if we still can't find a taper point, we would say, CVP is definitely very elevated, obviously. Okay, we're moving on to some IVCs now. So this first one is a short axis IVC. You've got spine deep there. You've got aorta, and then this is our intrahepatic portion of the IVC, looking very elliptoid. So as a reminder, in the short axis, one of the most important things we're looking for is IVC shape, and whether it's rounded and spherical, which correlates to a high CVP, or kind of elliptoid and collapsing, as is in this case, that would support a non-elevated normal CVP. This is another short axis, and just to demonstrate here that you can actually see the hepatic veins pouring into that short axis IVC. So when we're scanning in short axis, we want to make sure we're following the IVC up to the right atrium to see the hepatic veins inserting, and then come down a centimeter or two after the hepatic vein insertion, because that's where we want to sort of assess our IVC for its shape. And we do that with a fanning motion. Have a look at the IVC video for more examples of this. Again, a short axis IVC, you've got aorta there to kind of screen right over top of the spine, and then IVC to screen left within the liver. A very spherical shape here, again, with minimal change with respiration. This, again, would correlate to an elevated CVP. Here we have a long axis IVC. So we're using the curvilinear probe on the abdominal preset. Heart is to screen left because I can sort of see some movement there. We don't clearly see hepatic vein draining into the IVC in this view, which ideally we would see, but we can see two kind of bright hyperechoic walls of the IVC. And we see probably at least 50% respiratory collapse. As a reminder, we always want to look in two views. We would want to check this in short axis and make sure that we're not just seeing the IVC moving in and out of our plane of view with respiration. Here's another short axis view with kind of the hepatic veins coming right into the IVC there we see. And again, minimal respiratory change in its size and quite a rounded shape. So again, I would say this is a plethoric IVC, consistent with a high CVP. Here is, on contrast, quite an ovoid IVC. So we see a bit of a hepatic vein above it, and then the IVC itself looks quite elliptoid, collapsed, a bit triangular, not sort of really rounded like we saw in the previous slide. Here's a familiar long axis view. Heart is on screen right. We see the non-plethoric hepatic vein kind of draining into the IVC there. And then we see the intrahepatic part of the IVC. And we can see some respiratory change. Again, apologies that this clip is so patchy, but probably at least 50% if we eyeball this. Here's another short axis IVC with pretty significant collapse going on, as well as a really ovoid shape. So this would be a non-plethoric IVC in short axis, and we'd want to confirm in long axis as well, of course. Here's a long axis IVC, a huge right atrium taking up a lot of our screen there, a bit of a hepatic vein draining into it, and then a big IVC, minimal respiratory variation, just looking very plethoric here. So we could pause this when we had a good picture and good bright parallel IVC walls and measure this, but even just looking at it without measuring, I would say this IVC is quite plethoric. Here's another short axis IVC lying right there within the liver. And again, quite elliptoid, and you can also see some respiratory variation in this view. So typically we look for IVC collapsibility in a long axis view, but we can also get a sense of it in short axis as well, as we do here. Here's an IVC in long axis. Heart is over there on screen right, and hepatic vein coming into it. And it's a good example of false collapse of the IVC. So you may think that the IVC is collapsing with respiration, but really it's moving laterally out of our plane of vision with respiration. And the clue there is that we are losing those kind of nice hyperechoic borders of the IVC, and it looks like the liver is just kind of invading into the IVC. So this is another reason to do a short axis view, because it can help you tease out this versus true collapse. Here's a short axis view that is kind of middling, to be honest. The IVC looks fairly spherical. There's a little bit of respiratory change, not a ton. And as a reminder, IVCs aren't always in one camp or the other. There's a lot of IVCs that are going to fall into kind of a gray zone where they're, not super convincing either way. It's hard to interpret them. And we want to avoid trying to overcall those IVCs and make clinical inferences where we shouldn't. The IVC, like a lot of POCUS parameters, is most useful at extremes. And some of these IVCs in the middle just aren't going to be that helpful. Again, please have a look at the dedicated IVC video for lots more on this. This is an IVC taken from a transhepatic view, or kind of a lateral approach in that coronal plane going through the liver. We can sort of get a sense of right atrium. We can see some of hepatic vein in the liver there. We see a bit of aorta deep to it, and then we see IVC nicely coming through there. And this is a really nice rescue view if you can't see the IVC from a traditional subxiphoid approach. A reminder that if we're looking in this view, we also want to try to look in short axis in this transhepatic view as well, because most IVCs are taller than they are wide. So if we're only looking in a lateral view like this, we may falsely overestimate the size of the IVC. So important, as always, to look in a couple views. This is just a nice long axis view, heart on screen right. We really see those bright, crisp, hyperechoic borders of the IVC. And we can see that with respiration, there's minimal change of the IVC. A reminder that we don't want to train our eyes right at the diaphragm where there is a little bit of movement, because the diaphragm itself can kind of pinch the IVC shut or stent it open. So we want to look 1 to 2 centimeters past the hepatic vein. Another short axis IVC that looks quite round and plethoric and non-varying. This is another kind of middling IVC that I wouldn't necessarily put too much weight in. So it's fairly rounded. It looks a bit more elliptoid as we follow it through. Again, this might be an IVC that's kind of in the gray zone. I would certainly want more data. This is another good example of probably some false collapse with respiration. Although this does look like a fairly big IVC, we think we're seeing some collapse, but you note that the borders of the IVC are kind of just eroding there. It looks like the liver is encroaching on the IVC. So my guess would be that this IVC is just moving out of our plane of view with respiration. So a short axis view is a really nice check of that. You can see if the IVC actually is changing in size or if it's just moving laterally as the patient breathes. This is a transhepatic IVC, not the best view. You can actually see some B lines there on screen left, but you can see, a segment of the IVC. So again, this wouldn't be perfect, but if this was all I had, then I would go ahead and measure the IVC here, certainly looking pretty plethoric, and I would try to do a short axis from this view as well. All right, that's it. So apologies again for the patchy slides, but hopefully those were some useful examples now that you've scanned some normal patients of what pathology can look like and some troubleshooting tips for these kinds of exams. Thanks.